A very good evening to all of you. So we are coming up with the next chapter in rheumatology, which is spondyloarthritis. The last class we spoke about rheumatoid arthritis, which is a very, very important essay question in your final year, as well as the MCQs, the management especially. So moving on to the next topic, which is actually spondyloarthritis. So before we go into what is actually spondyloarthritis, I would like you to know about a term called seronegative spondyloarthropathy. So this seronegative arthritis is what it was called earlier till recent times. And why do we call it as seronegative? Okay, why do we call it as seronegative? It is a very important thing that you need to remember. Yes. So seronegative means the RA factor will be negative. So we saw that in rheumatoid arthritis, the RA factor will be positive. Though it is not very specific to the disease, the RA factor positivity implies that the patient is at a higher risk for developing rheumatoid arthritis. So there are a few patients in whom the RA factor will be negative. Those patients are called seronegative patients. Okay, so that was grouped under seronegative arthritis. But now the terminology has changed, and they have found that these RA factor negative patients, many patients are having an axial predominant problem. What do we mean by axial predominant problem? That means that the spine is getting involved in these patients. Okay, so the spine is getting involved in these patients. Okay, so what do we mean by this seronegative spondyloarthropathy? The RA factor will be negative, and in some cases, the spine is also getting involved. Okay, so let us now look on to what is spondyloarthropathy. The patients with spondyloarthropathies have the presence of HLA-B27. They are commonly associated with this HLA-B27. Okay, so each of the arthritis will be associated with one type of HLA. Okay, autoimmune diseases will be associated with one type of HLA. So this spondyloarthropathies, they are associated with HLA-B27. This is very important MCQ point. Okay, HLA-B27. Okay, so what are the types of this spondyloarthropathy? There are two types, right? There are two types. So what are the types? The first one will be axial predominant. Okay, axial predominant. And the next one will be peripheral predominant. What do we mean by that? Peripheral predominant? The peripheral joints like the knee joint, the ankle joint, the wrist joints, the finger joints, all these are predominantly involved in the other joints. Whereas in axial involvement, the spine is most importantly involved. Okay, so let us now look at what is the axial predominant most common problem which we encounter. So the most common one which is axial predominant is something called AS, which is ankylosing spondylitis, right? Ankylosing. Okay, ankylosing spondylitis. So moving on to what are the peripheral predominant ones. The first one will be psoriatic arthritis, right? Psoriatic arthritis. The next one will be IBD-associated arthritis. What is IBD? Inflammatory bowel disease, right? So the arthritis associated with patients with IBD, inflammatory bowel disease, is called IBD-associated arthritis. So the peripheral predominant ones, the first one will be psoriatic arthritis. The second one will be IBD-associated arthritis. The third one will be reactive arthritis. We are going to see all of these in detail. Don't worry, we'll be covering all these things. Then reactive arthritis. And one more thing which is called asymmetrical oligoarthritis, right? Asymmetrical oligoarthritis. So the axial predominant one, which is AS, is ankylosing spondylitis. The peripheral predominant ones are mainly psoriatic arthritis, IBD-associated arthritis, reactive arthritis, and asymmetrical oligoarthritis, right? Asymmetrical oligoarthritis. Okay. So let's study the most important topic under this, which is, yes. So I've already discussed axial versus peripheral. What are the differences? Axial means mostly the spine will be involved. It does not mean that the other joints cannot be involved, but most predominantly spine will be involved. Whereas peripheral, the peripheral joints will be involved. Peripheral joints will be involved, right? So axial versus peripheral, right? So next, moving on, ankylosing spondylitis. So I'm sure many of you would have heard about this arthritis, this spondylitis. How does it happen? Why does it happen? That is what we're going to read in this. Okay. So first, let's start from the demographics, epidemiology. So in whom is this ankylosing spondylitis very common? Ankylosing spondylitis is very common in the age group of early 20s, right? It is very common in the age group of early 20s. Say around 16 or 17, the patients from 16 or 17 till around 24, 25 years, they start developing this ankylosing spondylitis. It is most commonly identified in the early 20s, right? Yes. So what is the ratio? Is it more common in females or more common in males? What do you think? It is more common in males in the ratio of 3:1. It is more common in the males in the ratio of 3:1. And in this HLA-B27, HLA-B27 is very, very important, and it is found in almost 90 to 95% of the patients. 90 to 95% of these patients with ankylosing spondylitis have been found to have this HLA-B27. Okay, HLA-B27 is found in around 90 to 95% of these patients, right? Yes. So this is very, very important. That's why I told you the seronegative arthritis with the positivity of HLA-B27, that is ankylosing spondylitis, in that 90 to 95% are associated with ankylosing spondylitis. Okay. So this is very, very important. Once we come to this ankylosing spondylitis, so what are the types of this? Right? Again, there are two types. Ankylosing spondylitis, there are two types. What are the two types? The first one will be non-radiographic. Non-radiographic, and the second one will be radiographic. Okay, non-radiographic and radiographic. So in ankylosing spondylitis, what is the hallmark of the disease? What is the hallmark of the disease ankylosing spondylitis? The most important hallmark is you will have sacroiliitis. Sacroiliitis. You know the sacroiliac joint, right? In that there will be inflammation. So the hallmark of this ankylosing spondylitis is sacroiliitis. Definitely the patient with ankylosing spondylitis should have sacroiliitis. Then only you can call the patient as ankylosing spondylitis, which will almost be the initial stages only. Then the entire spine will get involved, right? So the first step will be sacroiliitis. This is very, very important. Okay. In this, what will we have? Non-radiographic. That means the X-ray will be normal. X-ray will be normal, but the MRI will show findings of, MRI will show sacroiliitis, right? MRI will show sacroiliitis. In the radiographic type, the X-ray itself will show sacroiliitis. X-ray will show sacroiliitis by itself. Okay. So in radiographic, the X-ray will show sacroiliitis, whereas in non-radiographic, the X-ray will be normal, but only when you do an MRI with high index of suspicion, then only the patient will be showing evidences of sacroiliitis. So this is very, very important. Okay. So among these patients who are showing sacroiliitis on the MRI with no findings on the X-ray, these patients you need to see if the HLA-B27 is present or not. Okay, you need to see whether the HLA-B27 is present or not. If it is present, then they have high risk of developing ankylosing spondylitis. They have high risk of developing ankylosing spondylitis. If the HLA-B27 is negative, then the risk is, there is no risk of developing, nil risk, almost nil risk of developing ankylosing spondylitis. So those patients who are having non-radiographic findings, the X-ray is normal, but the MRI is showing evidences of the sacroiliitis. In these patients, if you do the HLA-B27, if the HLA-B27 is positive, that means they have an increased risk of developing ankylosing spondylitis. Whereas in those who it is negative, that means that the patient is at less risk or nil risk of developing nil risk of developing ankylosing spondylitis. So this is a very, very important thing. You need to see whether it is radiographic or non-radiographic and whether they have HLA-B27 or not. So you can now understand the importance of HLA-B27 in ankylosing spondylitis. It is very, very important. Okay. Yes. Now moving on to the pathogenesis. So before we go into this image, I'll just tell you the pathogenesis by myself. Okay. Yes. So this is the pathogenesis. So there are few important factors are there. First is the genetic predisposition, right? You need to have this HLA-B27 positivity, right? Next, infections. What are the infections which are most important? Klebsiella pneumoniae, right? Klebsiella pneumoniae infections are very, very important. Klebsiella pneumoniae infections are very, very important. These may predispose the patient to develop ankylosing spondylitis. Next. So this includes the environmental factors also. Then one more important thing is gut microbiome dysgenesis, right? Gut microbiome dysgenesis. What do we mean by that? We all know that there are flora in the gut, right? So there is some disturbance in the gut microbiome, which is actually predisposing the patient to develop this this HLA-B27 positive spondyloarthropathy, which is ankylosing spondylitis, right? So the most important ones will be HLA-B27 positivity, the genetic predisposition, infections, and gut microbiome. Okay, this dysregulation in the gut microbiome will actually predispose the patient to develop ankylosing spondylitis. So how does this actually happen? When there's a gut microbiome dysgenesis, the epithelial layer will be affected, right? The gut lining will be affected. Epithelial layer is affected. Okay, what happens because of this gut epithelial layer being affected? The dendritic and macrophages, dendritic cells and the macrophages will get activated. Okay, so dendritic cells and macrophages are activated. Macrophages are stimulated. The dendritic cells and macrophages are stimulated. So because of this, what happens? There are few very, very important interleukins and TGF-beta is produced. Okay, because of this gut microbiome dysregulation, what happens? The interleukins and TGF-beta is produced, right? Interleukins and TGF-beta is produced. Because of this, what happens? There is something very important called interleukin 23 and interleukin 17. This becomes activated. Interleukin 23 and interleukin 17 becomes upregulated. Okay, these are all altered immune pathways. Because of that, what happened? The target tissues. What are the target tissues here? What are the target tissues here? The joints and the enthesis get inflamed. The joints and the enthesis are targeted. Because of this, what happens? There is inflammation. Because of that, what happens? There is inflammation, right? Because of that, what happens? There is inflammation. So what does the gut microbiome epithelial layer will be affected? Because of the dendritic cells and macrophages will be affected. The interleukin production will increase. Interleukin, especially interleukin 23 and interleukin 17. You need to remember this. Interleukin 23 and interleukin 17 is upregulated. Because of that, the joints and enthesis become inflamed. Okay, again, this Klebsiella pneumonia infection will also increase this interleukin 23 and interleukin 17. Because of that, the T cell activation will be there. T cell activation will be there, and which will cause autoimmunity, right? Autoimmunity. T cell activation will be there, which will cause autoimmunity. This is very, very important. So how does this HLA-B27 actually cause this ankylosing spondylitis? In this, what happens is there is some protein misfolding. Okay, some protein misfolding in the endoplasmic reticulum is there. Protein misfolding in the endoplasmic reticulum is there. So because of that, what happens? All these again interleukins will be increased, and this will cause inflammation in the joints and enthesis. So what do we call by enthesis? What is enthesis actually? It is a place where the ligaments or the tendon will attach to the bone, right? The ligaments or the tendons will come and attach to the bone. That area is called the enthesis. So what will you have when the joint is inflamed? You will have synovitis. When the enthesis is involved, it will cause enthesitis. Okay, what will happen? There is synovitis plus enthesitis. Okay, synovitis plus enthesitis. Okay, so what will happen because of that? You will have many formations. Because of this repeated inflammation and healing, what will happen? There will be some fibrosis. Also, TGF-beta is produced, which is pro-fibrotic. Okay, so because of that, what will happen? The spine will start fusing. Because of that, what will happen? Spine will start fusing. You understand? So the spine will start fusing. So how does this happen? The calcification of the annulus will happen because of this repeated inflammation and healing the body naturally. What will happen? There will be calcification, especially at the annulus. Calcification at the annulus. Because of that, what will happen? Syndesmophytes will be formed. You need to remember these words. Syndesmophytes will be formed. What is it? Syndesmophytes will be formed. Because of this repeated inflammation and healing, syndesmophytes will be formed. Then, what are these syndesmophytes? These are actually similar to osteophytes, which you find in the rheumatoid arthritis as well as in osteoarthritis. These osteophytes, which are thin, delicate, and they are not symmetrical. So these syndesmophytes will actually cause the fusion to happen, which will later result in the formation of bamboo spine. Bamboo spine. Why is it called bamboo spine? You can see the borders. You can see like in bamboo trees, you will have some thickening here like this. The spine will look like this, right? So this looks like a bamboo. So it is called a bamboo spine, right? So there is calcification of the annulus, which is happening. Okay. Yes. So we have seen the most important things. So let us look at this picture. HLA-B27, there's a genetic component involved. Yes, this is very important. HLA-B27 is needed. Then this gut regulation, gut microbiome dysregulation will happen. Then the mechanical stress will factors and environmental factors, especially infection, which I told you, Klebsiella pneumoniae infection is commonly implicated in this. This will call altered immune response regulation. Because of that, what will happen? Interleukin 23 and interleukin 17 will be activated. And because of that, there will be inflammation of the enthesis and joints. And there will be multi-system involvement will be there. Okay, so this arthritis is not just confined to the spine. You will definitely have extra-articular manifestations, right? You will have extra-articular manifestations. Okay, so let us now proceed with the next one. So what happens in this? Now this you can see here is a normal spine. You can see the intervertebral space. It is very clear. Okay, you have the intervertebral disc also, which is actually maintaining the distance and allowing the the spine to move out freely, right? Now, what happens when there is an inflammation? The joint space will be reduced, right? The ligaments, the ligaments come and join here, right? So wherever the ligaments are getting attached, in those places, there will be inflammation. So you will have enthesitis. And I told you this annulus will get inflamed because of the repeated thing. Calcification will be there, right? So bony protuberances, which are also called osteophytes, in this we call it as syndesmophytes, are formed. So because of that syndesmophytes, what happens? The spine gets fused. Okay, what happens? The spine gets fused. Okay, the spine will get fused. This is called bamboo spine. Bamboo spine. Okay, so this is the picturistic representation so that you will remember easily. Okay, yes. So let us know what are the clinical features. Clinical features. So I told you what is the hallmark of the disease. The hallmark is sacroiliitis. Hallmark is sacroiliitis. This is very, very important. Sacroiliitis is the most important. So what are the other joints getting affected most commonly? Hip joint, or the shoulder joint can also be affected. Hip joint or the shoulder joint are most commonly affected in ankylosing spondylitis. Okay, I told you the age when it comes is in the early 20s. Okay, till when we are seeing before 45 years, actually you can find that these symptoms manifest. Okay, symptoms manifest. Most common is early 20s, but it will be anytime less than 45 years, you will be able to identify the patients. Okay, symptoms will be seen in patients those less than 45 years itself. And when will you call this ankylosing spondylitis? If you have this pain for one day, will you call it ankylosing spondylitis? No, it must be a chronic pain, right? Chronic low back pain, right? Chronic low back pain, especially duration should be more than 3 months. Duration should be more than 3 months. This is very, very important. It should be a chronic pain. Chronic pain is a must, right? Chronic pain, and the hallmark is sacroiliitis, which must be definitely important. So what will patient have? The patient will have a very deep-seated low back pain, right? The patient will have a very deep-seated low back pain. Okay. One more characteristic thing that you should remember is the patient can also have chronic alternating buttock pain. Chronic alternating buttock pain. What do you mean by this? One day, one gluteal region will be paining. The next day, the other gluteal region will be paining. So this alternating buttock pain is called alternating gluteal region pain. Is very, very characteristically seen in ankylosing spondylitis. Okay, the patient can have a deep-seated low back pain, or the patient can have a chronic alternating buttock pain, which is very, very important, and it is most commonly found only in ankylosing spondylitis. So this is a very important clinical feature. Okay. So along with this, what will the patient have? We saw in rheumatoid arthritis that the patient will have stiffness, right? Again, these patients with ankylosing spondylitis also will have morning stiffness lasting for more than 30 minutes. Morning stiffness lasting for more than 30 minutes. This is very important. The patient will have morning stiffness which will last for more than 30 minutes. Okay, more than 30 minutes. And how does the pain vary? How does the pain vary? Does this pain increase with rest or get relieved by rest? This pain will actually be relieved by activity. Okay, if you have morning stiffness and you're just resting, this is not going to improve. As you get up and move on with your daily activity, then this pain will actually reduce. So this is relieved with activity. This pain, the characteristic of this pain is that it will be relieved with activity and increases on rest. Relieved with activity and increases at rest. It increases at rest and it is relieved with activity. Okay, then nocturnal pain will be there, right? Nocturnal pain. We are just characterizing the pain of ankylosing spondylitis. The deep-seated low back pain or the alternating buttock pain will be associated with some morning stiffness of more than 30 minutes, and it will be relieved with activity and it will be increased at rest. It will be nocturnal pain also. So gradually what happens as these things proceed, there will be loss of lumbar lordosis. Loss of lumbar lordosis. Loss of lumbar lordosis will be there, and the patient can also have plantar fasciitis. Plantar fasciitis can also be there. Okay, so plantar fasciitis can also be there. So what are the articular manifestations? Most commonly, the sacroiliac joint will be involved. The other common things will be hip joint and shoulder joint can also be involved. The symptoms will be seen in early 20s, but most commonly in patients less than 45 years, you can still identify these patients. Then the duration should be chronic. It should be at least more than 3 months. The pain should be a deep-seated low back pain or a chronic alternating buttock pain with a morning stiffness of more than 30 minutes. It should be relieved with activity, or it should increase at rest. The pain should have also nocturnal pain. That is, in sleep also you will be able to perceive the pain, and you may have to get up because of the pain at night. And there will be loss of lumbar lordosis, and the patient may also develop plantar fasciitis. These are all the clinical features, the articular manifestations. How do we characterize the pain in these patients? Right? So moving on to the extra-articular manifestations. What are the extra-articular manifestations? So the first one, eyes. What will you find in eyes? You will have acute anterior uveitis. Acute anterior uveitis. There are many times when the patient will have an acute anterior uveitis, and the patient is then referred to the rheumatologist to find out whether the patient is having HLA-B27 positivity and has developed ankylosing spondylitis. So the uveitis may be the first presentation of ankylosing spondylitis. This is very, very important. When I was in my UG, then I've seen a patient with this ankylosing spondylitis who had presented to the ophthalmology unit when I was doing my ophthalmology internship. Okay, so that is when we identified the patient and we asked them to go and consult a rheumatologist. And when we reviewed the patient, we found out that he was HLA-B27 positive subsequently. Okay, so uveitis may be the first presentation of this ankylosing spondylitis, right? So it is acute anterior uveitis. Okay, so what are the other extra-articular manifestations? For eyes, you will have acute anterior uveitis. Then lungs. What will you find in the lungs? You will have non-specific interstitial pneumonia. Non-specific interstitial pneumonia will be there, which is actually predominant in the upper lobe more than lower lobe. Okay, non-specific interstitial pneumonia more predominantly in the upper lobe more than the lower lobe. Okay, so in lungs you will have non-specific interstitial pneumonia. What will you find in the heart? Cardiac involvement, you will find aortic regurgitation. Aortic regurgitation, or you can also have ascending aorta inflammation, which is ascending aortitis. Okay, ascending aortitis can be there. So cardiac aortic regurgitation will be there, or you can also have ascending aortitis. This is very, very important. Cardiac manifestations of ankylosing spondylitis is the patient can have aortic regurgitation, or the patient can have ascending aortitis. Right, ascending aortitis. Next, what is the fourth one? So you have seen eyes, lungs, and cardiac involvement. Next will be the renal involvement. In patients with chronic rheumatological illnesses, the patient will actually develop amyloidosis. This is one thing, amyloidosis will be there. So because of that, the patient can develop proteinuria and renal failure. So amyloidosis is one manifestation of that. The other most important thing is the patient can develop IgA nephropathy, secondary IgA nephropathy. Okay, secondary IgA nephropathy. This is very, very important. Chronic illnesses, they can develop amyloidosis. Chronic rheumatological disease, especially, they can develop amyloidosis. And because of that proteinuria and renal failure, that is one manifestation. But more important one is IgA nephropathy developing in these patients. Okay, so the ocular involvement, lungs involvement, cardiac involvement, and the renal involvement we have seen. Now, next one will be bone. You have seen the articular manifestations, but apart from that, what else will the patient have? Can also have osteoporosis. Osteoporosis. You may think because of this repeated inflammation, calcification is happening, but there is more bone is there. But no, the patient is osteoporotic. The patient's bones will be osteoporotic. So next, the neurological involvement. The patient can have cauda equina syndrome. Cauda equina syndrome, especially more so because of the compression, because of the bone, the intervertebral bones, the intervertebral disc calcification of that, the bones get collapsed. I mean, the joint space will be reduced, and this will cause compression of the nerves getting out from this from these regions. So this will cause cauda equina syndrome. So the extra-articular manifestations, among that, the most important one is acute anterior uveitis. This is the most important one. Can be the first presentation in these patients. Then lungs will cause, in the lung involvement, it will cause non-specific interstitial pneumonia, predominant in the upper lobe more than the lower lobe. Cardiac involvement can cause aortic regurgitation or ascending aortitis. Renal involvement can cause amyloidosis or IgA nephropathy, which is more important. Then bone involvement, osteoporosis can be there, and the neurological involvement, cauda equina syndrome, is most commonly seen. Okay, these are all the extra-articular manifestations. Right. Moving on to the examination. So we are now moving on to the examination. Right. So examination. This named test, you need to remember, this is called Schober's test. This is called Schober's test. So what happens? You actually ask the patient to stand straight. Right. You ask the patient to stand straight, and you locate the posterior superior iliac spine. You locate the posterior superior iliac spine. Then you name a point here, which is 10 centimeters above the posterior superior iliac spine. And this is called the point A. Okay. And then from this point, posterior superior iliac spine, you label a point 5 centimeters below that as point B. Okay. As point B. Then you ask the patient to bend forward without bending his knee. Okay, you ask the patient to bend forward without bending his knee or ankle, and you actually measure the distance between this A and B. Actually, this should be 15 centimeters. In total, it is 15 centimeters, right? So what happens in these patients? If it is more than 20 centimeters, then means the patient is normal. Okay, if it is more than 20 centimeters, and the patient is normal. But what happens in ankylosing spondylitis? Because of the bone fusion, what will happen? The patient is not able to bend down completely, and the distance does not increase. If the difference is not more than 5 centimeters, and the difference is not more than 5 centimeters, that is, if it is less than 20 centimeters, like 18 centimeters or something like that, 17 or 18 centimeters, that means that the patient is having ankylosing spondylitis. That means that the patient is having ankylosing spondylitis. The difference should not be more than 5 centimeters. Okay, I mean, it should be less than 5 centimeters. It should be, like around 16 to 20. If it is between that, then it means that the patient is having ankylosing spondylitis. So this is very, very important. There are some more tests, like checking the head tilt and the chin, the deviation. All these things are also there. But this name test, you must remember, and it is a very, very clinical significant. This is called Schober's test. Okay, so you locate the posterior superior iliac spine. You label a point A above the posterior superior iliac spine at 10 centimeters, and a point below that at 5 centimeters, point B. So measure the distance when the patient is actually bending forward, and not without bending the knee and ankle. You must keep that in mind. The knee and ankle should not be bent. Okay, and the difference is less than 5 centimeters. Okay, what should be that? Then it means that the patient is having ankylosing spondylitis. If it is more than 20 centimeters, then it means that the patient is not having ankylosing spondylitis. Okay, yes. So moving on to the investigations. So let's see one by one. So what are the most important investigations? Non-specific ones you will already be knowing. The ESR and CRP will be elevated, right? ESR and CRP will be increased, right? ESR and CRP will be increased. Then the most important one, HLA-B27 will be positive. HLA-B27 will be positive. This is diagnostic. HLA-B27 will be positive. This will be diagnostic in around 90% of cases. 90 to 95% cases. Okay, this HLA-B27 will be positive. Then, third one, the X-ray will show sacroiliitis, right? X-ray will show sacroiliitis. There is a grading for that. There is a grading. In that, 1 to 4 will be there. So grade 4 will be complete ankylosis. In that, you need to remember this grade 4, complete ankylosis. What do you mean by ankylosis? There is complete fusion, right? So complete fusion of the joints will be there. The intervertebral joints, there will be complete fusion. Okay, so that is called that is called grade 4, complete ankylosis. Grade 4 is complete ankylosis, right? Yes. So this is the findings of X-ray. In MRI, if you're not able to find out in sacroiliitis, to look for non-radiographic ankylosing spondylitis, what should you do? You should do an MRI, which will very different, usually identify this early sacroiliitis. It will be able to pick up this early sacroiliitis. So this is very, very important. Early sacroiliitis, early inflammation, early edema is always found out on MRI easily. So if you do an MRI, you will be able to identify the early sacroiliitis. Early sacroiliitis is very commonly and very easily identifiable. Right? Yes. So there is some criteria which you must remember. Okay. This is called the modified New York criteria. What is it called? It's called the modified New York criteria for diagnosing ankylosing spondylitis. Okay, modified New York criteria. Among this, what do you have? You have two things, right? One is the radiological criteria, and the other one is clinical criteria. So you have radiological criteria and clinical criteria. Okay, so first let us look at the radiological criteria. In this, you have sacroiliitis, right? You need to have sacroiliitis. And the sacroiliitis grade should be at least more than 2, right? You should be more than or equal to 2, which is bilateral. Bilateral sacroiliitis be there, and it should be at least more than grade. Okay, so that is called, that comes under the radiological criteria. So one more thing, you can have sacroiliitis. But unilaterally it can be grade 3 or grade 4. Okay, so one side sacroiliac joint is normal, but on the other side you find that it is grade 4, complete ankylosis of that joint is there. Then it means that still it can mean that the patient is having ankylosing spondylitis. So unilaterally it can be 3 or 4. Grade 3 or grade 4 can be there. Okay, so what are the clinical criteria? First one, low back pain should be there. Low back pain. We already discussed all the clinical criteria, correlations with that. The low back pain should be chronic. It should be increased with activity, improving with activity, increasing with activity, and increasing on rest and improving with activity. That is very important. Low back pain. The next one is alternating buttock pain can be there. You will have morning stiffness more than 30 minutes. Nocturnal pain can be there. All these are important attributes with low back pain, right? This low back pain should be chronic, associated with stiffness. It should be associated with stiffness. Then it should improve with activity. And it should be more than 3 months. All these things are important. More than 3 months. These things are important. These are important attributes and comes under the clinical criteria. So what is the second one? There should be limitation of range of movement. Okay, limitation of range of movement should be there. Okay, not just pain, but there should be some amount of limitation of range of movement should also be there. Especially the forward bending or the lateral bending. All these limitation of movement should be there. So if this limitation of movement is there, then it comes under the criteria of ankylosing spondylitis. Then third one, limitation of chest expansion. Okay, if the chest expansion is normally 5 centimeters in the adult, 5 to 6 centimeters, then there should be less than 2 or 3 centimeters. It should be around 2 or 3 centimeters. There should be some amount of limitation of chest expansion. Okay, so this is the radiological criteria and the clinical criteria. When will you say that the patient is having definite ankylosing spondylitis? When will you say that the patient is having definite ankylosing spondylitis? When will you say that? That is when there is radiological criteria plus one clinical criteria, at least one clinical criteria. Radiological criteria plus at least one clinical criteria should be there. So the radiological criteria plus at least one clinical criteria should be there to call that the patient is having ankylosing spondylitis. So this is very, very important. The radiological criteria is the sacroiliitis more than or equal to 2, which is bilateral, or sacroiliitis unilateral. If it is there, then it should be more than, the grade should be more than 3 or 4. Then the clinical features, low back pain, like I told you, it should be associated with stiffness, it should improve with activity, and the duration should be more than 3 months. There should be limitation of range of movements and the limitation of chest expansion. At least one clinical criteria should be there, and the patient should have radiological criteria. Then we say that the patient is having a definite, this definite ankylosing spondylitis. Okay. So before we proceed, I want you to know some named signs in ankylosing spondylitis. So the first one we already studied. Radiologic sign findings. First one you already studied, which is bamboo spine. There will be a thickening here. Again here. This looks like the internodes and the nodes of the bamboo tree. Right? So this is called bamboo spine. Next one. There are some erosions which are named. Erosions of which are named, which is Ramenis sign. Ramenis sign. Okay, this you must remember, Ramenis sign. This can be asked as an MCQ. So Ramenis sign, these are erosions on the bone which are seen in ankylosing spondylitis. Then the third one, something called a dagger spine. Something called a dagger. So what happens in this? The interspinous ligament is calcified. Interspinous ligament is calcified. What will happen because of that? You can see these are the vertebrae, and you will find that there is a thickening here. There's a calcification here. The interspinous ligament is calcified. Okay. So then fourth one will be railroad or tram track sign. Railroad or tram track sign. Okay. What is this because of? This is because of the joint capsule getting calcified. Joint capsule getting calcified. Right? The joint capsule is getting calcified. Because of that, how will it be? So here there will be inflammation. Okay. Here there will be inflammation and there will be calcification. Okay. When you have a combination of both the dagger spine and railroad spine, which will be like this. You have a bone, you have the vertebrae, so you have the interspinous ligament calcification as well as the joint capsule getting calcified. In these patients, it will look like this. This is called the trolley track sign. What is this called? Trolley track sign. This is called a trolley track sign. This you must remember: bamboo spine, dagger spine, railroad spine, trolley track sign. All these are very important. Bamboo spine. You have some erosions also called Ramenis sign, dagger spine. Okay. And what is it called? Railroad or railroad spine is there. Then you have a trolley track spine. Okay. Trolley track spine will be there. Okay. So I think these pictures are clear. Bamboo spine, the intervertebral space will be calcified. In dagger spine, the interspinous ligament calcification will be there. In the track sign, what will happen? The joint, right? In trolley track sign, what will happen? Both the dagger sign as well as the railroad sign is present. So it is called a trolley track sign. Okay. These are some names which you must remember, and it can be asked in the MCQs. Okay. So moving on to the treatment. So how do we treat these patients? So the first one will be starting treatment will be trying to give the patient some analgesics. Trying to give the patient some safe analgesics or anti-inflammatories. Anti-inflammatories. Right? Analgesics or anti-inflammatories can be given. The second thing, the first line will be NSAIDs, which is usually given for 2 to 4 weeks. NSAIDs, which is given for 2 to 4 weeks. Unless contraindicated. Okay. So NSAIDs are the first line. You can give it for 2 to 4 weeks. But what is the main, mainstay of treatment in this? Main thing is important is physiotherapy. We already saw that the pain improves with activity, right? So you need to keep the joint active, mobile, so that the pain will be relieved and the inflammation will also be reduced. So physiotherapy is very, very important. Okay. So if the pain is not relieved with analgesics, what can we do? You can give intra-articular steroids. You can give intra-articular steroids, which will actually reduce the inflammation inside the joint. So intra-articular steroids are given for pain relief. Intra-articular steroids are given for pain relief. Now, what is the next one? We can give TNF alpha blockers, right? TNF alpha blockers are given, which will actually cause the disease progression to be subsided. The disease progression can be stopped if you give TNF alpha. Okay. But what happens in TNF alpha blockers? They will try to improve the motility, but the disease progression will not be affected to much extent. Okay. Disease progression not affected much. Disease progression will not be affected much. And TNF alpha blockers are given even in IBD patients, but this will actually cause the disease progression to be subsided. But in these patients with ankylosing spondylitis, it is a very progressive disease. So even if you give TNF alpha blockers, the disease progression cannot be affected much, but the mobility will be improved. Okay, but the mobility will be improved. So this is very, very important. Mobility will be improved. Okay. So the treatment mainstay will be analgesics, trial of analgesics for 2 to 4 weeks, intra-articular steroids for pain relief, TNF alpha blockers, which actually do not modify the disease progression, but actually improve the mobility, and physiotherapy. This is very, very important. Physiotherapy is an important aspect. Almost lifelong physiotherapy is needed. Okay. Lifelong physiotherapy is needed for these patients. Okay. What is Reters syndrome? Okay. What is Reters syndrome? This is also called reactive arthritis. Right? This is also called reactive arthritis. So we first saw the axial predominant spondyloarthritis, which is ankylosing spondylitis. Now we move on to the peripheral ones. We'll just touch upon all these things. Okay, these are like short notes in your exams. So what is Reters syndrome or reactive arthritis? So the patient can be having a urinary infection or a gut infection. Gut infection, most commonly gastroenteritis, a urinary infection with any organism. So the patient will, after this, what will happen? The patient will develop a joint inflammation. Most commonly, it will be a knee joint or a shoulder joint. Most commonly, the knee joint will be involved. Okay, the patient will have a reactive arthritis. Okay, because of the infection, the patient is developing a reactivity in the joint. So this is called reactive arthritis. Okay, this has a characteristic triad. Has a characteristic triad. What is that triad? We need to know. What is that triad that we need to know? So these patients will have arthritis, urethritis, urethritis, and conjunctivitis. Arthritis, urethritis, and conjunctivitis. Okay. So, which infection? Most commonly enteric. Enteric or urinary infections. Enteric or urinary infections are most common, right? Among this, the most common organism will be chlamydia. Chlamydia. Okay. Chlamydia infections is the most common organism. So, what are the characteristics? We know that this is peripheral predominant, right? Peripheral predominant. Then, we know that in this, the RA factor will be negative. It is seronegative. So, RA factor will be negative. Then, HLA-B27 will be positive. But in around 70% of patients, we saw that in what is that ankylosing spondylitis, you have 90 to 95% positivity. In these patients, Reters syndrome or reactive arthritis, around 70% will be positive. If the 70% of patients, when you actually follow them up over a longer period of time, you will find that they will have a chronic reactive arthritis. They will have a chronic reactive arthritis. Usually this reactive arthritis will come and subside by itself. But when patients who are positive for HLA-B27 and those who are developing reactive arthritis, they have a risk of progressing to chronic reactive arthritis. Chronic reactive arthritis. So this is very, very important. Chronic reactive arthritis. So what is the triad? We have to recollect once again. It is triad of arthritis, urethritis, and conjunctivitis. Reactive arthritis is most commonly caused by an enteric or urinary infection. It is seronegative. So RA factor is negative. HLA-B27 is positive because it's a spondyloarthropathy, right? It's positive in around 70% of patients. If the patient is having an HLA-B27 positive and is developing a reactive arthritis, the patient is having an increased risk of growing into chronic reactive arthritis, right? He has a risk of growing into chronic reactive arthritis. So how about joint involvement in these patients? The joint involvement will be asymmetric, right? The joint involvement will be asymmetric. So the patient can have just one knee involvement or one ankle involvement. Okay. The patient does not need to have bilateral ankle involvement or bilateral knee involvement. So it is asymmetric and it is very painful. So what happens, the patient will come to you with a reactive arthritis, but the patient will come to you with a joint pain, and you will start treating the patient for some other complications. But you need to get a good history, so that you have to find out whether the patient, this episode of joint pain was actually preceded by an enteric infection, a gastroenteritis, or a urinary infection. Then if you take a good history, then you'll be able to identify whether this is a reactive arthritis or not. Right. So the most common joint involved, which I told you, is knee joint, followed by ankle, or the subtalar joints, or the MTP joints. Subtalar joints or MTP joints are commonly involved, but the most common is knee. Knee joint will be involved. Okay. In this, you have an X-ray finding which is called sausage digits. This is called sausage digits. What is this sausage digit? What is the sausage digit? There will be diffuse swelling of fingers and toes. Diffuse swelling of fingers and toes, right? These are called sausage digits. You will have diffuse swelling of the fingers and toes. This is very important. It's a peripheral predominant, seronegative, factor negative, spondyloarthropathy, HLA-B20, around 70% of patients. Triad is arthritis, urethritis, conjunctivitis. So it is usually preceded by an enteric infection or a urinary infection. The joint involvement is usually asymmetric and it is painful, right? And you have some sausage digits. The most common joint involved is knee joint. Ankle joints, subtalar joints, and MTP joints can also be involved. Okay, so this also has some extra-articular manifestations. This also has some extra-articular manifestations, but few are named, which you must remember very surely. You can see here, there are some lesions on the palms and the soles, right? Soles of the foot. So you can see here, there is some protruding kerato, a lot of keratosis will be there. Hyperkeratotic lesions will be there. So what is this called? Keratoderma blenorigica. Keratoderma blenorigica. Okay, keratoderma blenorigica. What are these actually? These are vesicles, hyperkeratotic vesicles on the palms and soles. Usually the whole hand can be involved, or the entire soles can also be involved of the feet. Okay, so this is called keratoderma blenorigica. These are hyperkeratotic vesicles. Hyperkeratotic vesicles. Hyperkeratosis is very, very important. Hyperkeratotic vesicles. Okay, so the next one, mucosal involvement. So the glans penis can be most commonly involved, and this is called cercinate balanitis. Cercinate balanitis. The involvement of the glans is called balanitis. The inflammation of the glans is called balanitis, and this is called cercinate balanitis. We have shallow ulcers. Shallow ulcers on the glans penis. Okay, shallow ulcers on the glans penis will be there. Again, ocular involvement, what will you have? You will have uveitis. Ocular involvement, you will have uveitis. Uveitis we saw also in ankylosing spondylitis, acute anti-uveitis, where it can be the first manifestation of the patient developing ankylosing spondylitis. So this is very, very important. In cardiac, again, you will have aortic regurgitation. In cardiac, you will have again aortic regurgitation. Axial involvement can also be there. Like this, axial involvement can also be there. The patient can also have asymmetric sacroiliitis. Asymmetric sacroiliitis. You can also have some oral ulcers, right? The mucosa is getting involved in the glans penis. It can also get involved in the oral cavity. So you can have some ulcers in the oral cavity. Okay. So what are the extra-articular manifestations? You can have uveitis, you can have cercinate balanitis, you can have keratoderma blenorigica, you can have asymmetric sacroiliitis, and the cardiac involvement, you can have aortic regurgitation. Aortic regurgitation. So in these patients, what will happen? How will you diagnose this? Again, this is very non-specific. You need to get a good history. ESR, CRP should be elevated. ESR, CRP should be there elevated. You can do a synovial fluid analysis, which will show neutrophil inflammation. Okay. So, synovial fluid analysis can be done. How do you treat these patients? You can give NSAIDs, anti-inflammatories. NSAIDs can be given. These are the mainstay. In patients who are having chronic reactive arthritis, in those patients, you can actually give sulfasalazine. Okay, sulfasalazine can be given. Sulfasalazine can be given only in chronic persistent reactive arthritis. Chronic persistent reactive arthritis. Okay, so NSAID is the mainstay of treatment. Sulfasalazine you can give, right, in chronic reactive arthritis. Right. So we have now seen Ankylosing spondylitis and reactive arthritis, which is peripheral predominant. So moving on to the next peripheral predominant one, psoriatic arthritis. Right? The next one will be psoriatic arthritis. Okay. So patients developing psoriatic arthritis, they have a psoriasis, they have a predisposition to develop arthritis. They can also have some other extra-articular manifestations, but psoriasis is most commonly associated with arthritis. This is called psoriatic arthritis. You know, how frequent is it? It is around 7 to 40% of patients. It's a wide range of, you have a wide range here. It is as less as 70% to as high as 40%. Almost half of the patients with psoriasis can develop psoriatic arthritis, or it can be very, very minimal. Okay, so patients with psoriasis can develop psoriatic arthritis, and the range is quite wide, between 7 to 40%. Okay, so when is it most commonly seen? We saw ankylosing spondylitis or reactive arthritis. They are most commonly in the younger age group. Whereas psoriatic arthritis, in these patients, it is a slightly higher age group, more than 40 years. Okay, age group is more than 40 years. Right, the age group is more than 40 years. Okay, so what do we see in these patients? So usually in around 60% of the patients, psoriasis will be first, right? Psoriasis will come first and the arthritis then develops. Okay, in 60% of the patients of our psoriasis, the initial presentation will be psoriasis in around 60% of patients. Whereas in 20% of patients, both can present at the same time. They can present with psoriatic arthritis as well as psoriasis skin lesions at the same time. Whereas in 20% of patients, they can have arthritis first. Arthritis first. Okay, arthritis first. So in 60% of patients with psoriasis, they first will develop psoriatic skin lesions, right? And then they may develop arthritis. But in 20% of patients, they will develop arthritis first and later go on to develop skin lesions. In around 20% of patients, they can have both presenting at the same time. Okay, so this is very important, epidemiological point of interest that you should remember. In this, what is the most important thing that you need to remember? What is the most important thing that you should remember? These patients will have DIP joint involvement. We saw when we were studying about rheumatoid arthritis, if there is a DIP joint involvement, don't think about rheumatoid arthritis. That is what we were saying, right? So when there is a DIP joint involvement, then you should think about psoriatic arthritis definitely. Okay, distal interphalangeal joint is involved, then it is most commonly psoriatic arthritis. It is not involved in rheumatoid arthritis. Okay, still interphalangeal joint involvement, psoriatic arthritis. You will also have dactylitis. Okay, dactylitis will be there, right? So DIP and dactylitis. This one is an erosive arthritis. Psoriatic arthritis is an erosive arthritis, right? You were studying this in the rheumatoid arthritis chapter. We were looking at the differential diagnosis for erosive arthritis and non-erosive arthritis. So psoriatic arthritis is an erosive arthritis. Okay. What are the associated nail changes? You must be knowing all these things. Associated nail changes are nail pitting. Okay. Nail pitting is very, very common. Onycholysis, lysis of the nails, onycholysis. Then oil drop sign. All these are important nail findings associated with that. You already know the skin lesions. There will be flaking. There will be erythema. There will be flaking. All these things are very important. Right? So this is very, very important. So on the X-ray, what will you find? You will have pencil in cup appearance. Pencil in cup appearance. Okay. Right. So pencil in cup appearance. On the X-ray, you will have pencil in cup appearance. So what do we actually find? You can see here. How is this location? Usually it is like this. And now it is like this. Okay. You can see that this is just going into this. How will it usually be? It will usually be like this. They will just approximate, right? This looks like as if in this patients, in psoriatic arthritis patients, it looks as if this is going into this. This is called telescoping. Telescoping of joints. This is called telescoping of joints. The lower joint is actually trying to fit into that. Okay. So this is called telescoping of joints. Okay. This is called telescoping of joints. Okay. So you will have pencil in cup appearance and you can have telescoping of joints. This is very, very common. And you will have, when you have DIP involvement, when you have PIP involvement, as well as MCP involvement, if you have erosions in these places, then you can have a ray pattern. Okay. You can have a ray pattern. Right, ray pattern will be there. So you have a pencil and cup deformity, right? Pencil and cup deformity, telescoping of joints, as well as ray pattern on the X-ray. Okay, this is very, very important. See, like I told you, so this is normal. Normally, you can see that these two regions are approximating, but in this, what will happen is there is a pencil and cup deformity. This is a cup, and there's as if a pencil is being put into that. So this is called a pencil and cup deformity. Okay, this is just for you to remember easily. This is also called telescoping of joints. Okay, yes. So what is the drug of choice for these patients? We have already discussed this. The patients you need to give TNF alpha inhibitors, right? TNF alpha agents. The drug of choice will be TNF alpha inhibitors. The drug of choice will be TNF alpha inhibitors. These are very, very important. TNF alpha inhibitors. What is the side effect of these TNF alpha inhibitors? Most commonly, you will see a lupus flare. Okay, lupus flare in these patients on TNF alpha inhibitors. Right. Other things like cytopenias, all those are also common. Infection risk. All those things are there for any biologicals. But with TNF alpha inhibitors, the lupus flare is the most important side effect that you must remember. Okay. What are the other agents that you can give? Methotrexate, leflunomide, all these things you can give. Okay, you can also give PDE4 inhibitors, phosphodiesterase inhibitors. All these can also be given for these patients with psoriatic arthritis. Like I told you, most of the patients will develop psoriasis first and then progress to develop arthritis. There are a few subset of patients who develop arthritis first and then go on to develop psoriasis skin lesions. There is one subset of patients in whom they can present simultaneously with both skin lesions as well as arthritis. Okay, so you must remember this chronology and the sequential present way in which they can present. Okay, so that you don't dismiss any cases easily. Just because you have skin lesions, you cannot just send off the patient, even though he's having a IP involvement. So you must definitely work up for psoriasis. Okay, yes. So next, moving on to the last one, IBD-associated arthritis. Among the peripheral, what we have discussed reactive arthritis, psoriatic arthritis, and next is IBD-associated arthritis, right? So patients with Crohn's or ulcerative colitis, they can develop arthritis, right? So IBD is inflammatory bowel disease. These patients can develop Crohn's disease or ulcerative colitis. They can have associated arthritis. Okay. In this, we an axial involvement or a peripheral involvement or can be both. They can have an axial involvement or a peripheral involvement or there can be both. Okay. And most important is this is non-erosive, right? We saw that the psoriatic arthritis was an erosive arthritis, whereas IBD-associated arthritis is non-erosive arthritis. Okay. And this arthritis actually correlates with the disease activity. So actually the patient may be having a flare of Crohn's disease or ulcerative colitis. The patient can be having a flare of the IBD, and that time the patient is developing a arthritic lesion, also IBD-associated arthritis. So actually this arthritis actually correlates with the disease activity. Okay, it correlates with the disease activity. It is common in both males and females in the ratio of 1:1. It can be any 50-50. Okay, so male and female 50-50. And again, this is a disease of the young in less than 30 years. In less than 30 years, you can actually develop this IBD-associated arthritis. It's not usually older people. It is usually the lesser age group. Okay, less than 30 years. And it is more common in Crohn's than ulcerative colitis. So it is more commonly seen in patients with Crohn's disease than ulcerative colitis. Right? It is most commonly seen in patients with Crohn's disease than ulcerative colitis. Again, here the anti-inflammatory, which is actually going to decrease the disease progression, will be anti-TNF alpha. We studied in the first one, ankylosing spondylitis, you can give anti-TNF alpha agents, but it is not going to modify the disease progression. Whereas in IBD-associated arthritis and psoriasis, it will modify the disease progression. So anti-TNF alpha agents are very, very important. They're very, very important, like rituximab and adalimumab. These are very, very important. Okay. Then, if the patient is developing associated arthritis, the patient is also having episcleritis or erythema nodosum. The patient is having IBD, he's also having some extra-intestinal manifestations like episcleritis, arthritis, or erythema nodosum. Then this will correlate with relapse. So you may have taken treatment and you may be in remission, but if the patient is having episcleritis and erythema nodosum, it means that they have a propensity to relapse again. Okay. So arthritis associated with disease activity, whereas episcleritis and erythema nodosum are associated with the relapses. They correlate with the relapses. Okay. So we've now touched upon the axial lesions, and the axial most important will be ankylosing spondylitis, and the peripheral involvement, which will be most commonly IBD-associated arthritis, psoriatic arthritis, as well as reactive arthritis. Okay, so let us now just have a quick recap of what we have studied. So now you will be telling how we are going to differentiate all these things. Okay. Okay. So the first thing we'll have ankylosing spondylitis, then psoriatic arthritis. Then we saw about reactive arthritis and IBD-associated arthritis. Right, IBD-associated arthritis. So what is the gender predisposition? In ankylosing spondylitis, we saw that the males are more commonly involved in the ratio of 3:1. 3:1. In psoriatic arthritis, it's 1:1. In Reiter syndrome also, it is 1:1. In IBD also, it is 1:1. Right. In reactive arthritis, among that, if the patient is having a urinary infection, then it is increased risk. If the patient is having a urinary infection, then the risk is more common, especially in the females. So females are more predisposed to urinary infections, right? So the patients around 9:1 is the ratio. So patients with urinary infection who develop reactive arthritis, it is more common among the females in the ratio of 9:1. Okay, it is as high as 9:1. Okay, because urinary infections are more common among the females, right? Then the age group. We saw that except for one thing, all others are more commonly found in the younger age group. So which is that one thing? Psoriatic arthritis is found in patients more than 40 years, whereas all the other things are seen in young people, less than 20 or 30 years. Okay, less than 30 years. So this is very, very important. Okay, only in psoriatic arthritis is found in the older age group. It is found in the older age group. So in ankylosing spondylitis, what do we have? I told you the joints are also involved as well as the entheses are being involved. So you have synovitis plus enthesitis. Synovitis plus enthesitis will be there. In psoriatic arthritis, I told you the most important one will be dactylitis. The most important one will be dactylitis. Along with that, you will also have synovitis and enthesitis. You will have dactylitis plus synovitis plus enthesitis. This is very important. Dactylitis is most commonly found in psoriasis. So dactylitis is very, very important. Dactylitis is very, very important. Synovitis with enthesitis in ankylosing spondylitis. In psoriatic arthritis, you have dactylitis, synovitis, as well as enthesitis. Okay. In reactive arthritis, you will have again all the three. Whereas in IBD-associated arthritis is most commonly only synovitis. Entheses are not involved. We told it is non-erosive. Non-erosive, right? It is non-erosive. Okay. Then dactylitis, you must remember, is psoriatic arthritis as well as reactive arthritis. And in IBD-associated arthritis is non-erosive, so you have only synovitis. Okay, next moving on. What is the treatment? For ankylosing spondylitis, you have NSAIDs. You can give TNF-alpha inhibitors, but it is not of much use because it does not alter the disease progression. Physiotherapy is very, very important, which actually improves the mobility. Right? You can give NSAIDs, physiotherapy, and TNF-alpha agents. In psoriatic arthritis, you can give TNF-alpha agents. Okay, you can give TNF-alpha agents. And reactive arthritis, you can give NSAIDs. Again, in reactive arthritis, you can give NSAIDs. Okay, so this is just a revision of what we have studied so far. Right? I hope it's useful for you. Come back with the next topic in rheumatology. Thank you so much.